There's 6 main determinants of lung volume. As we age, our lungs tend to be more inefficient and have worse V to Q ratios, especially um, in the setting of smoking or chronic diseases such as asthma and COPD. Men also tend to have larger and longer chest walls and tend to be taller. Weight is also a common sense determinant, as adipose tissues tend to distribute along the abdomen and chest wall. Race can also influence lung volumes. For example, people of African descent tend to have a longer torso and hence longer lungs. And last but not least, disease is probably the most important here. So people with obstructive lung diseases through asthma or through long-term smoking or restrictive lung diseases have increased or reduced lung volumes. In the next several slides, we will illustrate some common sense approaches to understanding lung volume changes in disease states. To best understand the lung in health and disease, we must recognize common lung volumes and lung capacities. Spirometry is a measurement tool that provides an objective way to measure these lung volumes in our patients and can be helpful in the diagnosis of various types of lung diseases. But before we talk about the measurement tool itself, let's have a look at what the normal values for these things are. So let's begin with tidal volume, and tidal volume is what you are currently doing as you are listening to this video. This is the normal ebb and flow, the normal inhale and exhale while at rest, and this is about 500 milliliters or so. At the peak of a normal breath, a normal tidal breath is seen here. If one inhales the most they possibly can for maximum inspiration, this is called the inspiratory reserve volume, and this is approximately 3 liters or so. On the other hand, at the end of a normal tidal volume breath, if one were to exhale as much as possible, when you reach a natural stopping point, this is called the expiratory reserve volume. So you've got the inspiratory reserve volume and the expiratory reserve volume, and this is about 1.1 liters. The remaining air in the lung is called the residual volume, and it's about 1.2 liters, and it's impossible to exhale this from the lungs. This is literally what is left over to keep your lungs inflated so they don't collapse on themselves. So in review, we have tidal volume, we've got inspiratory reserve volume, we've got expiratory reserve volume, and we've got residual volume. Residual volume is not able to change. Not able to be exhaled. When using these 4 measurements, we're able to calculate lung capacities, which are helpful when talking about restrictive and obstructive lung diseases. The first capacity to talk about is the functional residual capacity. And this is the combination of all of the air at the end of a tidal breath. So this is the addition of the expiratory reserve volume plus the residual volume, the total being about 2.3 liters. Now the second one to know is from the bottom of a normal tidal breath to the maximum inspiration, this is called the inspiratory capacity, and this is about 3.5 liters. Number 3, the vital capacity, is composed of all of the air from maximum inspiration all the way down to maximum expiration, totaling about 4.6 liters. And the last capacity to know is the easiest to remember, is the total lung capacity, is everything including the residual volume, totaling about 5.8 liters. Please memorize all of the volumes and capacities for testing. As we begin to walk through lung diseases in coming lectures, 2 categories stick out: obstructive and restrictive lung diseases. Obstructive lung diseases are conditions of air trapping in which air has difficulty leaving the lung once it's inhaled. These can be acute diseases and chronic diseases. In restrictive diseases, these are lung conditions of having low compliance, hence having difficulty moving air out very well. Asthma is a condition of having an acute or reactive airway disease where terminal bronchioles constrict in reaction to something like pollen or pollution or what have you. When the bronchioles constrict, air is able to get in but is not able to get out very well, and it becomes trapped. Over time, this will eventually be released, or other things like medications like albuterol or ipratropium, these can relax this bronchoconstriction. COPD is a chronic obstructive lung disease, as the name implies. And this is due to slow destruction of elastin in the airways. Elastin keeps this tube patent, both on the inhale and the exhale. Now, during exhalation, as elastin is destroyed, airways tend to collapse during exhalation, leaving leaving air trapped inside and typically increasing the size of the alveoli itself. So here air is able to move in, but it is not able to leave. On the right side, restrictive lung diseases restrict the lung's ability to expand appropriately. Here compliance is poor. It's really so poor, or the elasticity or the recoil is so high, that one loses the ability to inhale and exhale gases for sustainable life. And typically these are progressive diseases with poor prognoses. These can be intrapulmonic diseases or conditions occurring within the lung, like black lung, which is typically found in coal miners. Mesothelioma is another kind of pulmonary disease, which is a malignant form of fibrosis, typically on the bases of the lung, which restrict the lung's ability to expand. Or idiopathic pulmonary fibrosis, which is an intrapulmonic disease of the alveoli and the spaces between the alveoli. A form of extrapulmonic lung disease that's restrictive would be something like scoliosis. In the next slides, we'll compare how lung volumes and capacities compared to a healthy person, and how we can assess these diseases through pulmonary function testing like spirometry. Obstructive lung disease is characterized by destruction of elastin and progressive air trapping. If elastin is to provide a natural rubber band-like recoil to pull the lung back into its original shape and volume, destroyed elastin can't properly do this. So the baseline resting volume, it begins to grow. So that, coupled with air trapping, increases the volumes of the lungs themselves over decades, and this is called hyperinflation. The hallmark of obstructive lung diseases is an increased total lung capacity from loss of elastic recoil and hyperinflation. And here we can compare normal to severe emphysematous disease. You can see evidence of this in the stepwise kind of increase in residual volume as severity increases, like so. I like to equate this with something similar to a growing air pocket tumor, which slowly crowds out the tidal volume and the inspiratory reserve volume. So these begin to decline as well, tidal volume and inspiratory reserve volume. Another measurement used to judge and to look at obstructive lung diseases is the RV to TLC ratio, or the residual volume compared to the total lung capacity. This ratio slowly rises with severity. And to review the notes on the right, the RV is elevated due to airway closure and airway trapping. The functional reserve capacity, which we remember is the expiratory reserve volume plus the residual volume, we can see this increases as well, and this is due to hyperinflation. Next, the inspiratory reserve volume. This begins to decrease, so we can see kind of a mild to moderate decrease with each step. And it decreases as alveoli are more and more distended to their own limit. And lastly, vital capacity decreases. And vital capacity, as a quick review, is going to be everything from maximal inspiration to expiration. So over the severity of the disease, this is going to reduce. Let's look at some main points when we look at restrictive lung diseases in terms of lung volumes and lung capacities. Restrictive diseases like pulmonary fibrosis, severe morbid obesity, and scoliosis are characterized by a restriction in the ability to expand the chest wall, as well as restriction or compression of lung volumes and capacities. Now, the hallmark of restrictive lung diseases is reduced total lung capacity. Please asterisk this. And we can see overall that this is fairly apparent when comparing restrictive diseases to somebody with a normal chest wall compared to somebody with an obstructive disease like COPD. It's pretty significant. Baked into this is going to be a lower residual volume. This is going to be pretty significantly compressed compared with obstructive and normal. And let me link these two here. A lower vital capacity, and this is one's ability to inhale and exhale maximally. And lastly, we will see a compression of the inspiratory capacity, We'll say right here, inspiratory capacity. And this is due to higher elastic work overall, no matter the disease. So I mentioned a few before. There are many restrictive lung diseases, and probably the most common is going to be obesity. And this is where the abdominal adipose tissue causes more work on inspiration and a reduced expiratory reserve volume. So with the reduced expiratory reserve volume, we see these in neuromuscular disorders as well as obesity. So when we compare restrictive to obstructive lung diseases, we see that in restrictive diseases, the total lung capacity is remarkably smaller. The vital capacity, or again, that maximal inspiration to expiration, is also reduced. And lastly, and more interestingly, is the tidal volume here is much reduced compared to obstructive lung disease in somebody that has a normal chest wall and lungs. So that tidal volume, that resting breathing, it's compressed, and this makes people with restrictive lung disorders have a lower minute ventilation, and that's the amount of alveolar gas that's diffused. And anyone with a lower minute ventilation has to increase their respiratory rate to make up for it. So the respiratory rate for somebody with a restrictive disease is typically elevated. So if the respiratory rate for somebody with a normal chest wall and lungs is, say, 12 to 16 times per minute, somebody with a restrictive lung disease might have something like 15 to 20 or even higher. Good, so just to review, the hallmark of restrictive lung disease is going to be that reduced total lung capacity, as well as with a reduced residual volume and reduced vital capacity and inspiratory capacity as well. Spirometry is a technique to measure airflow and lung volumes for the diagnosis of obstructive and restrictive lung diseases. The procedure is pretty simple. The patient places his or her mouth around the device, inhales as much as he can, and then exhales as fast as possible until full exhalation. And let's see if we can trace that here. So here is normal tidal volume. And then the patient will inhale as much as possible until maximal inhalation, and then will exhale as fast as possible. And this is called vital capacity. So it is full inspiration to full exhalation. And when done in a forced maneuver, this is called forced vital capacity, or FVC. And as seen here, this forced vital capacity is a volume. Now, if you'll remember, the vital capacity, or even the forced vital capacity, is going to be affected by restrictive lung diseases like pulmonary fibrosis, severe obesity, neuromuscular diseases, and the list goes on and on. So the question is, how do we know if this forced vital capacity is normal or within normal range or not? Well, the answer is that we can use age, height, weight, race, and all of the other determinants of lung volume, and we can actually plug them into a calculator, and we can get what's called a predicted forced vital capacity number. So then what we can do is take that predicted number, or that measured number of the FVC, and we can compare it with what we've measured in somebody when somebody takes in that deep breath and then exhales as much as possible. And we say if that measured number is 80% of that predicted number, then we say that this is normal. However, if that FVC is less than 80%, then this is suggestive of, but not diagnostic of, a restrictive lung disease. Next, what we're going to do is to place this forced vital capacity, this FVC volume, into something called a flow volume loop in the next slide, and we're going to discuss how it's used to diagnose various airway diseases. Now, a second measurement is needed to help us understand flow rate problems, and this is called the forced expiratory volume in 1 second. In shorthand, this is the FEV1, and really is volume per unit time, or liters per second, which makes this a flow rate. So now that we understand and know how to calculate the forced vital capacity, which is volume, which is maximal inhalation to maximal exhalation in a forced maneuver, now my question is going to be, how much of this can you get out in 1 second? So that question we can actually represent in a ratio of forced expiratory volume, or the amount of air that you can blow out in 1 second, over the total amount that you can exhale. And pulmonologists have come up with an arbitrary number. Obviously, this is going to be a percentage or a fraction, and they say that if your FEV1 over FVC, or if the total amount that you can blow out over in 1 second is about 70% of your forced vital capacity, then you're okay. Then your lungs are operating normally. You can exhale just fine. But if you have 60 or 50%, then this is where we have a diagnosis of obstructive lung disease. And these would be something like asthma or COPD. Again, so in obstructive lung diseases, we find that the ability to get one's air out forcibly doesn't go very well because airways collapse. So this is airways disease. And so that reduces the ratio. In the next slide, what we'll do is we are going to visually represent this in something called a flow volume loop, which is a visual kind of illustration of that can be helpful in the diagnosis of obstructive lung diseases and restrictive lung diseases. In the last few slides, we reviewed the forced expiratory volume in 1 second as well as the forced vital capacity. The forced expiratory volume in 1 second is a flow rate, and the forced vital capacity is just that, it's a volume. We also discussed the ratio of FEV1 over FVC. If this ratio is greater than or equal to 70%, you're considered normal. If it's less than 70%, this is a diagnosis of obstruction. So after that quick review, what we can do is discuss a flow volume loop. And in order to do this, I'm going to make 3 graphs to discuss normal, obstructive, and restrictive lung diseases. So a flow volume loop is represented by an x and a y axis. This x-axis is going to be volume in liters. The y-axis is going to be flow rate in liters per second. So when somebody is hooked up to a spirometer, they put their mouth on the little breathing tube and they forcefully exhale as much as they can. Their flow volume loop is going to kind of look like a lopsided pear. Let me draw it first, and then we're going to discuss why it looks the way that it does. And I'm going to trace this down the middle here, and I'd encourage you to do the same thing. And before we talk about anything else, let me draw a pair of lungs here, so we can talk about these two in tandem. So with somebody with normal lungs, the initial portion of the flow volume loop is actually going to be positive. It's going to be aggressively steep, which means that air is able to be evacuated very quickly from the lungs. And then eventually it's going to heat this peak point right here. So this portion, which I'm highlighting in green, I'm actually going to highlight the portion in the lungs that this represents. So this represents all of the large and medium-sized airways that have little to no resistance, and I'm actually going to write that here. So the area in green is going to be large airways, which means low resistance. So air is able to be evacuated pretty quickly. So this second portion, which is more of a gradual decline in the graph, is going to be represented by the small airways. So this is the terminal bronchioles and the alveoli themselves. So this peak represented right here is actually an area, a wall, if you will, of increased resistance, which is reflected here in the periphery. So this slow and gradual decline in flow rate is represented by small airways with higher resistance. And then eventually it's going to reach this point here. And what is this point? Let's see, we've got volume. Where have we seen that before? If we've got volume and it's the total amount that you can exhale, this is the forced vital capacity. And then one inhales. And this inhalation is typically pretty symmetrical and takes on kind of an ovoid shape. So just to clarify here, this is all, this is all exhalation. And all of this is inhalation. So just to recap, we've got part A over here, which is going to be your large airways. This is reflected in a very vigorous flow rate. And then we reach a peak here, which is the onset of resistance to this, to the division between large and medium-sized airways to small airways. And in part B is represented by small airways. So if that's normal, what does it look like in obstruction? Well, what I'm going to do is I'm going to mark out the FVC, which is typically about normal in somebody with obstructive lung disease. And the flow rate, which I'll reflect as this peak up here, is going to be about the same as well. But we're going to see a couple of marked differences here. So as somebody exhales, you're going to get to this peak. You're going to arrive at this border between the large and medium-sized airways to the small airways. And instead of this slow, precipitous drop, as reflected up here, of normal airways, now we know that diseases like asthma and COPD have problems with airways collapsing. So when airways collapse, that flow rate is going to reduce. So instead of this, it's going to suddenly drop and eventually arrive at the FVC. So this is characterized as something called a scooped appearance or a scooped out appearance. And again, this is, if I were to divide these two up between large and medium-sized airways, it's those, large and small airways, those small airways are going to be the main problem here. So to summarize it, it has a scooped appearance due to elevated resistance from airway collapse. And then we inhale and start it all over again. And the inhalation is typically equivalent to that of a normal flow volume loop. So what about restrictive lung disease? Well, if the FVC, which is seen on both the normal and the obstructive flow volume loops, is here, somebody that has restrictive lung disease, this is shrunk. Let's use a different color. This is shrunk. So the FVC is now here. And that peak of expiration, again hitting that wall of resistance, can be normal or mildly reduced. And here what you will see is essentially a squashing of the entire normal flow volume loop. So you'll have a precipitous rise of those large airways, which are okay, and then what will happen is that this will be smushed, whereas normally it would have been more to the right, and then the inhalation will happen. So this is exhalation, this is inhalation. So in this example, what we see is a reduction in the FVC and an overall compression of the normal flow volume loop to the left. Now, this is just one example of restrictive lung disease, and these can take all sorts of wild shapes. We're going to discuss more of this in class, but I wanted to give you kind of the foundational understanding of what a normal flow volume loop looks like compared to obstructive and compared to restrictive. Main points to remember in obstructive is going to be that scooped out appearance. Main point to represent from restrictive lung disease is the reduction in the FVC. Just to summarize a couple of final points about the diagnosis of obstructive lung disease and restrictive lung disease, we can diagnose obstructive lung disease based off of this reduced ratio of FEV1 over FVC. If it's less than 70%, you have your diagnosis. In terms of restrictive lung disease, this ratio can actually be normal or high. And what I'm going to do is write this out to demonstrate it really quickly. So somebody with restrictive lung disease can actually have, typically has a reduced vital capacity because their lungs are compressed. This is also can be reflected in a reduced forced expiratory volume in 1 second, especially if somebody has something like a neuromuscular disease. So what this looks like in somebody with restrictive lung disease is that this ratio can be normal or it can be elevated, it can be high. So by that I mean greater than 70%. So because there can be a lot of variability depending on one's kind of diagnosis of restrictive lung disease, meaning it could be fibrotic, it could be neuromuscular, or due to scoliosis, we diagnose restrictive lung disease more based on total lung capacity, which we can determine in spirometry readings. So based on somebody's age, based on somebody's height, based on somebody's weight and race, and the other determinants of lung volume that we've talked about previously, we're able to calculate a predicted total lung capacity. If somebody has 80% or less, I should say, let me correct myself, if somebody has less than 80% of a predicted total lung capacity, then they have a diagnosis of restrictive lung disease. So again, the FEV1 over FVC can have a lot of variability in somebody with restrictive lung disease, and instead what we use is that total lung capacity as the marker for restrictive diagnosis.